Hello, my name is Dr. Mohammed Assous. I'm a consultant endoscopic spine surgeon from Razi Spine Clinic in Amman, Jordan. I welcome you all today. We are going to do a fully endoscopic spinal canal decompression because of severe stenosis in a 72-year-old gentleman who is troubled with severe symptoms of spinal canal stenosis, as you will see in a minute when we discuss things with him. So I'm going to talk to Mr. Majid Al-Far, a 72-year-old gentleman from Jordan, and then we will go to the operating theater and carry out the surgery under general anesthetic through 1 centimeter incision for each level. So we will do 2 levels, L2, L3 and L4, L5. Each of them will be done through 1 centimeter incision under general anesthetic, and he will be able to go home later today. So this is again a daycare surgery, and we will go through the steps in details and take you through it. So in behalf of all of you, I'd like to welcome and thank Mr. Majid Al-Far Abu Omar. We call him Abu Omar because he's very, very friendly character. And I'm going to ask him now what is spinal canal stenosis is doing to affect his life, and see what the problems he has from it. And then we'll go through a few details before we go to theater. So Abu Omar, salamat. How are you?
Good to see you, doctor.
Thank you so much for allowing us the opportunity to really record your surgery, because spinal canal stenosis, which is narrowing of the spinal canal, is very common and it affects a huge number of people. The main problem with it, as you will tell us now, is mainly when you stand up and when you walk. So can I ask you, what's the problem if in a bad day, for example, how far can you walk if you have a really tough day, for example?
This actually comes in different times. It could be, any time in the day. Walking maybe maximum 10 minutes, and then I have to sit down someplace.
Yes.
Looking for a stone or anything, I have to sit down.
Yes.
And, sometimes sit down 3-4 times.
So even for 100-meter distance, you have maybe to do it in stages 2-3 times, and you have to sit, at any time.
Yeah, sometimes, shopping or
yes,
or in the kitchen even,
right.
Just standing, cutting some onions, or, you have to sit in a chair.
So even a simple job in the kitchen, maybe preparing a small meal will be very troublesome, and you can't keep standing. You have to sit down, and then you have to stand up again.
Becomes a big project.
Yeah. And how long you've had this problem for, Abu Omar?
Almost 7 years.
7 years. Is it getting worse, better with time, or is it the same?
It's getting much worse.
It's getting much worse.
Yeah.
Right. And this is typical of spinal canal stenosis, because it really is a wear and tear problem, Abu Omar, and with time many people experience actually worsening of their symptoms. So as we know, you have this happening in 2 levels, at L2, L3 and L4, L5. And in your case, L4, L5 is very, very severe. I will explain on the MRI to the viewers in a few minutes before we start what happens in spinal canal stenosis. But in L4, L5, you really have what we call degenerative spondylolisthesis. This in simple English means you have slip of one bone, one vertebra on top of the other one.
Right.
But this is the stable type, and this is critically important. And many patients in your position end up having fixation surgery, where patients basically have fusion and cages put in, and screws and bone graft, etc. This is a much bigger surgery, which you don't need, to be honest.
Yeah.
And the reason you don't need it, because the slip is stable, and with the endoscope, which is only 1 centimeter in diameter, is very small, so we can do all the job through 1 centimeter incision without affecting the stability of the spine. But if somebody does this in an open surgery and they cut out all the important ligaments, exactly, all the ligaments, all the muscles,
yes,
all the bones, then this slip will move further, and obviously you will have to have fusion surgery. But the trick is actually in doing it in a technique that does not make the stability unstable, if you like, and do unnecessary fusion. And I hope this message will come across to as many patients when they see this video, inshallah, and to as many doctors, because this is also very little known, fact to many surgeons, sadly, of course. But with the new techniques and technologies and more studies, and I'm hoping the new generation of surgeons will adopt these very new and brand new techniques, very advanced techniques, and do more and more decompressive surgeries without having to do unnecessary fusions.
I'm looking forward to see the progress and the technology and benefits everybody.
Yes, I thank you again. We will have two levels. It will take 2 hours, so each level will take 1 hour, so our surgery will take 2 hours, and it's universally done under general anesthetic. We'll have to put you to sleep, and this is all over the world. It is unlike the disc surgery when we come from the side, which can be comfortably and safely done under local anesthetic and sedation, but your surgery from the back is done under general anesthetic. So this is something also that I'd like to stress, because many patients, they see the video for the lady under local anesthetic and they ask for decompression to be done under local, and it's not possible. So we have to make this very clear. So we'll go to theater now. We will make the arrangements, and obviously we'll take some medications in the vein, and then you will have the general anesthetic. The surgery will take 2 hours, inshallah. So this is around 11 o'clock. By the time I physically start your surgery, it's going to be around 12 o'clock, because we take some time in preparation. The surgery will take 2 hours, so maybe around 2:30 I'll finish work, inshallah. And 3-4 hours after the surgery, you'll be able to walk and eat something and go home. So I suspect by 6 p.m. today,
sounds very good.
You will be able to go home comfortably and safely, inshallah.
Inshallah.
Okay.
Sounds very good, doctor.
Any questions? Anything?
No.
Okay.
Not after the surgery.
After the surgery, okay.
And having a cup of coffee.
Your coffee, it will be ready. Very good and big. Large cup of coffee for you. Okay.
Inshallah.
Okay. We are now in the operating theater to carry out endoscopic decompression at L4, L5, and L2, L3 for our star patient Abu Omar. I'd like to explain on the model here before we start what happens in degenerative lumbar canal stenosis. So basically what happens here is this is where the disc space, and this is the spinal canal in the lumbar spine at L4, L5, for example. And this is the thecal sac. This is the continuation of the spinal cord. And we can see already in the model here, there's plenty of space available to the thecal sac, to the nerves that actually supply our lower limbs, in terms of muscle power, sensation, etc. What happens in degenerative lumbar canal stenosis, which is narrowing of the spinal canal, is the hypertrophy. Basically, it's enlargement of the ligaments and the tissues and the bones in the facets, which are the joints behind the spine. All these actually accumulatively conspire to narrow the space available to the thecal sac. So instead of here, all this actually closes down, leaving very little space to the thecal sac. And this causes what we call a neurogenic claudication, which is what we heard from Abu Omar, is that he is really struggling big time with standing up and walking for any distances because of the narrowing of the spinal canal. This is the MRI of Abu Omar, lumbar spine, and these are the X-rays, the bending forward and the extending views. Let me explain what happens in lumbar canal stenosis again here. So this is a side view of the spine, and we can already see this is actually the thecal sac or the spinal cord, where all the nerves are. And we can already see that there is significant narrowing or stenosis at L4, L5, and at L2, L3. So the plan is to widen the space here using the endoscope and going through 1 centimeter incision to achieve decompression of the whole spinal canal in both sides, but only from going from one side only. So we'll do this at L4, L5 first, and then we'll do it at L2, L3. It usually takes around 1 hour per level, so this is a 2-hour surgery. And a few hours later, the patient should be able to go home comfortably, inshallah. So these are the cross sections on the MRI, and I'll put this here just to compare. So we are looking exactly at the same view. So this is the disc space, this is the spinal canal with the thecal sac, as we can see here. So this is L3, L4, which is a normal level. But if we look at L4, L5, we can see the difference immediately. So L4, L5 compared to L3, L4, which is normal, L4, L5 is really very tight and very narrow. And the reason is the hypertrophy, the enlargement of the ligaments, the facet joints, these two joints here in the back of the spine, in addition usually to a small and calcified disc, which is not the main problem, but all the above actually contribute to the narrowing of the diameter of the canal, causing the neurogenic claudication and the troubles that Abu Omar is experiencing now. This is L4, L5, and by the same token, this is L2, L3. It's slightly better, but again, it is very tight, and it definitely needs doing. So the idea on the model again here is that we go from one side, so the patient will be laid on the front, so his tummy is here, his back will be here during the surgery in the top, and this is L4, this is L4, L5 for example, and we go 1 centimeter cut stab incision here, and we clean up all the tissues and the ligaments in this space. But because of the virtue of the endoscope, it's very small size, I can reach into the other side. We call it the contralateral side. We can comfortably and safely reach into the other side all the way to the nerves and free up the canal on the right side, for example, if I am going from the left side, which is exactly what we are doing here today. So today we're going from the left side. So this is the right side, this is the left side. So I will go from the left side, remove the bone that is pressing on the nerves, remove the ligament, the yellow ligament or the ligamentum flavum, which is again a ligament that is essential part of the pressure on the nerves, but again reach into the right side to finish the job and free up the spinal canal. All is done from one side in the left side here, and only from 1 centimeter incision. So the anesthetist has actually put Abu Omar to sleep, and we're going to go through the surgery now and do exactly what I explained here. So by the end of the surgery, we should be able to see the canal free and all the nerves actually running free into it. And it's going to take 2-hour surgery, and then after that 3 or 4 hours he should be able to walk, have something to eat and drink, and after which he can safely and comfortably go home. The other extremely important issue that Abu Omar has is basically the spondylolisthesis. This is the slippage of one vertebra on top of the other one, and he has this at L4, L5. So L4 basically has moved forward by 3 to 4 millimeters, something like that. So if this is normal, so the actual bone, the actual vertebra has moved forward. And the reason it does in somebody who's 70 or 60 years old and above is because of the wear and tear, all the degenerative changes that happens in the disc, starts in the disc, and then it moves to the facet joints in the back here. All this makes the facet joints a little bit incompetent, they become weakened. So the vertebra actually slips forward, but the extremely important fact is that it stays there. So in most of cases of spondylolisthesis, slippage of vertebra, which is degenerative in people above the age of 60 and 70s, it is a stable type of slip. And because it's a stable type of slip, we don't really need to fuse the vertebrae by means of screws and metal cages and bone graft, etc., which is totally different and unnecessary surgery in this scenario. And the evidence actually is here. So these are the views where you actually bend your back forward and then as much as you can, and you lean backwards as much as you can. And I've drawn the line at in the back of L4. So this is L4, L5 vertebra, sorry, and this is L4 and this is L3. You can see that L3 and L4 are well aligned together in terms of the lines in the back of the vertebra. But when we come to L5, it's definitely lying behind L4. And the reason is again because L4 has slipped forward on top of L5, but it stayed there because the distance here, we call the slippage distance. This is a grade 1 spondylolisthesis, which is the mild form of the slippage. The distance here, when Abu Omar bent forward, is exactly the same distance actually when he leaned backward. And this is exactly the same distance actually you can see on the MRI here when he's laid on his back. So if this was an unstable type, it should have actually reduced itself, i.e. it should have come back in full alignment, but no, it hasn't. It's actually stayed slipped forward because it is a stable type. This is the same reason it hasn't moved between this view and that view and the MRI. So this is a stable spondylolisthesis, stable slippage. It's degenerative in type, it's very common. And if it's mild degree, like a grade 1, like Abu Omar, we absolutely do not, and I repeat, we do not need to fuse the vertebrae and fix them together, which is a much bigger and more importantly, unnecessary surgery. All what we need to do is decompress the spinal canal at L4, L5 and L2, L3. So by the end of the procedure, they become normal like L3, L4. But the technique has to preserve the stability of the spine by not taking more tissues, ligaments, muscles, and bone than we need. And only endoscopic and minimally invasive surgery can do that for us. So we go from one side, we open up this side, and we actually sneak underneath the other side and fully decompress it, reaching the other end of the nerve root. And we do that all from one side work, 1 centimeter incision for this one, 1 centimeter incision for L2, L3, and this is a day surgery, and he should be able to go home comfortably a few hours after the surgery. Thank you. We've now inserted the endoscope, as we can see here. So we made a 1 centimeter incision, and this is a working cannula, and this is the endoscope here. And you can see the endoscope has a light source, as we explained before, and has a working canal which we can work. And this is the irrigation. This is the water we pump all throughout the surgery, and it helps us to get a better view and stop the oozing, as we can see on the screen. So all this is done, and I can steer the endoscope, as you can see, to get into any tight spots to free up the canal. What I've done is we use the drill. This is a high-speed drill, and it actually removes the bone, which is hiding the ligamentum flavum, which I'll explain in a minute. So I'm using the drill just to remove the excessive bone. So what we can see, that's it, please. So I've used the drill and I opened up the space for the ligamentum flavum. Ligamentum flavum is the yellow ligament here, and you can see from the name, it has a stain that stains it yellow. And this is one of the major factors that causes spinal canal stenosis. So this ligament is usually 2-3 millimeter in thickness, and sometimes in stenosis it exceeds a centimeter or 2, causing severe compression and pressure. So this is the yellow ligament here. Once I remove that, we should be able to see the thecal sac just underneath there. So all this done, this is the beauty of the endoscope, because of the diameter of the scope, the small diameter, 1 centimeter, and the versatility of the endoscope is so versatile, so robust. I can go into the both sides. We've come in from the left side, as you can see here, and then we can reach into the other side. So this is actually the right side of the patient, but I can easily reach it, because, as I said, of the angle of the endoscope, the angle of the lens of the endoscope, and the size of it. So this is the yellow ligament. I'll start removing that, and shortly we should be able to see the thecal sac and the nerve roots. What we've done so far is complete the decompression on the left side, which is the more symptomatic side. Abu Amr has more pain on the left side, so this is the left side. That's it, please. So we completed the work on the left side, and this is the nerve root. This is the L5 nerve root on the left side here. So this is the nerve root. What we can see just underneath the nerve root is a small calcified disc. I'm pressing on the disc, and it really is small and certainly does not need removal in this case, and in fact in most cases of spinal canal stenosis, the degenerative type. What we need to do now is to go into the other side, as we can see here, remove the rest of the ligament. This is in fact the nerve root on the right side. So we can safely and comfortably complete the decompression on both sides by coming only from one side, like the left side in this case. This is the final view that we aim to see. This is the end of this level, L4, L5. So this is the thecal sac, the continuation of the spinal cord. This is the left side. This is the nerve root. This is the L5 nerve root on the left side. This is the small calcified disc that we do not remove because there's absolutely no point of doing that because it's not doing any pressure now. This is the right side. We were able to reach this side from the left side. So this is the right side of the thecal sac, and this is the nerve root. This is the free L5 nerve root on the right side, and we were able to do all this through a small 1 centimeter incision on the left side, and this is endoscopic lumbar canal stenosis decompression. Thank you. Hello and good morning. We are still with Ammo Abu Omar. We are 1 day after the surgery. We finished the surgery yesterday at 4 p.m. and this is 11 a.m. on the following day. We were discussing actually him going home yesterday on the same day of the surgery, but he was a little bit dizzy, perhaps from the anesthetic. So for his comfort more than anything else, we decided to keep him in the hospital. So since then he's actually walked, he had something to eat and drink, and he's feeling very, very, very happy and comfortable. So we're going to check on him now together. So good morning to you.
Good morning, sir, doctor.
How are you today?
I'm doing very good, actually.
Excellent, excellent. And you had the chance to walk. You took a few steps outside the room,
yes,
all the way down the corridor, which is around 20 meters.
I did a few times this morning.
A few times. You walked a few 20 meters
with no
distance.
pain at all, alhamdulillah.
Excellent.
We thank Allah for everything.
So there's no pain in your back?
No pain.
What about the pain, the severe pain you had in the buttocks and in the thighs?
It's completely disappeared.
Completely disappeared. That's fantastic news. I'm very pleased. Alhamdulillah, I'm very pleased to know that. Sometimes we see these dramatic improvements, and sometimes people take the good part of 4 weeks to 6 weeks to get better, but everybody gets significant improvement immediately. I'm very happy that you have no pain at all. What about the pain from the operation side? Do you have any pain in the back?
No pain, I don't feel anything.
No pain, no pain. We don't get much pain with a 1 centimeter cut usually.
Yeah.
I'm very happy to hear that. And what we need to know is just to go through very briefly with the instructions for after the surgery.
Yes.
So for the first month, Abu Omar, I'd like you to take a few walks every day, maybe 5 to 10 minutes each. Do not sit for prolonged periods of time. Maybe sit for 30 minutes, 45 minutes, then walk for 5 to 10 minutes, and then go back and sit for half an hour or 1 hour. And keep yourself in a dynamic state. Walk, sit, stand, and you can lay down for probably an hour or two, but keep yourself in a moving position. We need to keep that for a first month basically, but at the 1 month mark, basically I allow people to do anything. If somebody wants to go back to the gym and to do some exercises, swimming, etc., I allow them to do.
I promise to take it easy.
Yes.
And no running or no jogging or...
Exactly. No marathon running for you, young man. Okay. Well, I'm very pleased. Do you have any questions or any comments?
Not at this time. I feel so happy, and I don't know what to ask even.
If you have any questions, we will be seeing you in the clinic, of course, in scheduled appointments to keep an eye on things. I'm very happy, and in the end, I really would like, on behalf of everybody who works with me, to thank you so much for allowing us the opportunity to record your surgery, because so many people will look at this and they will know what endoscopic spinal decompression is. It's a simple surgery, and people recover immediately after it. The success rate is in the region of 90%, alhamdulillah. And hopefully more and more people and more surgeons will learn this new technique.
Be brave enough to do it.
Brave enough, interested enough, I would say, and keen enough to do it. So I'm very pleased to know that you are doing so well immediately after the surgery. The only thing I would ask you now is perhaps to stand up and take a few steps and tell me what's happened to your pains that you had before the surgery.
Right away.
So if you don't mind, yes please.
No problem.
How are you feeling, Abu Omar, in your back, in your legs?
No pain whatsoever.
No pain,
Everything is gone.
even from the surgery side.
Yeah, no, you made surgery?
We did a 3-hour surgery yesterday.
Okay.
Yes, I think so. Yes.
Okay.
So you have no pain. I'm very pleased to know.
I know
that.
I gave you a hard time, but you know,
No, your surgery was straightforward actually. Yeah, but
feeling very good.
I'm very pleased to see that. Fantastic, fantastic. The
Thank
other
you.
thing I notice is that everybody who has severe canal stenosis is that usually they walk with a bent back. You don't do that anymore.
I used to do that. I used to
Correct,
go like this
correct.
because the pain.
Correct. And the reason you also do it is actually you relatively widen the canal subconsciously,
You know, my wife
and you
is-
can take a few more steps. But now you don't have to do that.
Yeah, my wife every day tells me, walk straight, walk straight.
Walk straight. But you can't with severe
can't.
stenosis. You can't. But now, mashallah, you can.
Yeah, I can
Good.
almost jump.
You can jump. Don't jump, please. Fantastic. Thank you so much.
You're
So you can have your seat again. And I'm very pleased. I really am very pleased. You've done so well. You've been the star of everything. So on behalf of everybody, the secretarial, team and the operative team, the surgeons and the doctors and the anesthetists and the nurses and the technicians, and of course the camera team. On behalf of everybody, I thank you so much. And we'll see you in the clinic, inshallah. Thank you so much.
Thank you.
Thank you.
Appreciate it, doctor.
You're welcome. Hello again. We are 5 days now since the surgery of Uncle Abu Omar, Mr. Majid Al-Far. We did the surgery 5 days ago. We did full endoscopic decompression in L4, L5, and L2, L3. And this is his first visit in the clinic, and we'd like to check on him and see how he's been doing the last few days since his surgery. Salamat Abu Omar. How are you?
Doing excellent today. Very good.
Excellent. So it is 5 days since we did your surgery, yes?
Yes.
And how's your back pain? How's your leg pain? The pain that you told us before the surgery, when you walk for 5-10 minutes, you get very bad pain in the lower back and then the legs, to the degree that you have to stop walking and sit properly on any curb or any stone in the on the street. So how's the pain in the back and the leg?
Unbelievable, doctor. Unbelievable. Things that happened, I can't imagine that I am without pain now. I had a lot of pain for 10 years, and now it came to an end. Alhamdulillah.
Alhamdulillah.
So I'm very, very happy and thankful to you. That is really something to think about. A lot of people, maybe they're afraid of doing a surgery.
Absolutely.
But with this Mindar, right, it's amazing.
I'm very pleased to hear that. So you have no pain in your back or your leg?
No pain
At all?
at any
MashaAllah,
time.
MashaAllah, MashaAllah. That's
I walked 15 minutes today in downtown.
Downtown, right, in the city center, very busy, 15 minutes walk.
15, no pain.
No pain in the back.
Normally, I would sit 5 times in 15 minutes.
Wow.
Just find anything to sit on with lots of pain. And now it's amazing. So I'm doing very well. Thanks to Allah and to you.
Alhamdulillah.
And inshallah, that this pain will never come back to me.
It will, inshallah, it will never. I mean, once you open up the canal where the narrowing on the nerve and the pinched nerve, it doesn't usually come back. I mean, I honestly cannot remember a case where I have to redo stenosis. We do sometimes disc surgery because 1 in 10 patients may come back. Another fragment pops out and presses on the nerve, but in canal stenosis, it doesn't usually come back. So I'm very pleased to know that. So you walk downtown 15 minutes before the surgery. You would have actually staged that before the surgery 4 or 5 times.
Yeah, at least.
Sitting on any seat, anything. But today, 5 days after the surgery,
no pain whatsoever.
No pain whatsoever.
No pain.
15 minutes walk. I'm very pleased to know that. And what about the painkillers? Are you taking the painkillers we prescribed after the surgery?
What painkillers?
No painkillers at all.
No painkillers. Nobody told me to take painkillers.
I agree and I apologize. I mean, what's happened?
Also, painkillers are for pain. I have no pain.
I'm very happy. The reason I laugh is because it was by sheer mistake. Actually, we'd forgotten to to give you the prescription for the painkillers, and I can only apologize about that. But subhanallah, it's for good, because you didn't have any pain, so you did not need any painkillers. But there was a prescription for painkillers, and everybody takes a prescription. So I'm sorry about that, but I'm very pleased you don't have any pain, and I'm very pleased you didn't. Abu Umar, in the end of all this, on behalf of everybody again, and myself and the team, I'm very grateful for you for giving us the chance to record this. And I'm absolutely positive hundreds and thousands of patients will see this video, and they will learn and know what endoscopic spine surgery and what happens in the very common problem of spinal canal stenosis, narrowing of the canal in the lumbar spine because of the wear and tear changes, and what the endoscopic surgery can do for them very effectively and very safely.
Dr. Mohammed, it's my pleasure that this happened and came to you, and I'm very thankful.
You're very welcome. You're very welcome. Thank you so much. We will be seeing you in the clinic, so I'll probably see you in a month's time. I will not be surprised if you tell me that you've walked 3-4 kilometers next time. I recommend you build up, do it gradually, increase the walking distance a little bit. In the end of the day, we are recovering from surgery, so your normal walking 10-15 minutes a day, several times a day is okay. But once we go to the half hour, 1 hour, I would probably suggest you do that at 1 month, maybe after the surgery. Apart from that, climbing up the stairs, going down is absolutely fine. The normal walking is absolutely fine. Prolonged sitting, anything for more than an hour, probably is not a good idea for the first month. So keep yourself in motion, keep moving, and we wish you all the best. وما شاء الله عليك والله يحميك ويجعله بلسان حسناتك. And thank you so much.
Thank you. All thanks to you.
You're very welcome. Thank you.